Good afternoon. Welcome, everybody. We'll go ahead and get started with our webinar. Stephanie Kovalick is going to be our moderator for the panel today here in Taking the Next Leap in Value-Based Care. Stephanie, take it away.
Thank you, Travis. As Travis said, my name is Stephanie Kovalick, and I am the Chief Strategy Officer at Sage Growth Partners. We are a healthcare-focused market research, go-to-market strategy, and strategic marketing firm. And we recently supported a market study that DataGen was conducting to learn more about the state of value-based care. We questioned more than 100 healthcare executives across the country from hospitals and health systems. And with several alternative payment models having been in practical use for a few years now, we were curious to learn more about how they were feeling about value-based care and how they were positioning themselves to succeed within the value-based care models. And so the survey was conducted prior to the COVID pandemic. We're going to talk today about kind of the general state of how value-based care is progressing, where things might be accelerated or not as we move forward. A couple of housekeeping notes before we get started. We'll be asking you guys some polling questions throughout this webinar. And when we do that, you should see a pop-up window open. You can respond there. In addition, we welcome questions and hope to be able to answer those at the end of the session. If you'd like to ask a question, use the Q&A button that you should see at the bottom of your screen. Today, I'm proud and happy to be able to discuss these findings with my colleagues from across the healthcare industry, who I'd like to introduce now. We have Theresa Dreyer, the lead of value-based care at AAMC. Theresa leads collaboratives for over 40 academic medical centers participating in value-based care programs, BPCI, CJR, and OCM advocates for policy change within current and future APMs to better alternative payment models to better promote the AAMC's mission for health for all. We also have Nicole Harmon. Nicole is HANYS Solutions Vice President of Practice Advancement Strategies. Nicole works collaboratively with clients across New York State to create and execute a fully customized plan to achieve true transformation and provide the right care at the right place at the right time and by the right person. We also have John Kalamaras. John is the Manager of Business Intelligence Analytics at DataGen. John's expertise in Medicare bundled payment policy and his background in biostatistics and mathematics allow him to focus on translating policy into actionable analytics, streamlining production, developing products, and enhancing the user experience. And we also have Jessica Walradt. Jessica manages Northwestern Medicine's government value-based care portfolio, which includes BPCI Advanced, MSSP, OCM, and components of the Quality Payment Program. Next. Before we get started, we want to get a little bit more information about you. So at a high level, please use the polling tool that you should see right now to let us know what kinds of models you're currently participating in. Once we're done, we should be able to display this up on the screen for everybody to take a look at. And here's the answer. So looks like we have a good mix. About 5% of you are participating in capitation. That's an interesting statistic. Bundled payments topping the charts. And many of you, I guess a third of you, are participating in multiple programs. So this is pretty interesting. It's a nice mix. Thank you for participating in the poll. So as I mentioned earlier, we recently conducted a market study to understand more about where the healthcare system is in regard to their participation in and perception of value-based programs. To level set, here's a little bit of information about the survey respondents. Demographically and geographically, we had a fairly diverse group. The respondents represented about 38 states with an average of just under 3 respondents per state. The survey was focused mainly on the C-suite across hospitals and health systems and large physician organizations. Next. Overall, we saw that the percent of revenue organizations have tied to value-based payments is approaching 30%, with a fairly even distribution across size of hospital or health system, and physician groups are trailing a bit behind, but not far from that. With that background, we want to move on and have some more in-depth conversation about value-based care and how payment models might continue to shift in the US. We have a second polling question. When it comes to value-based programs, are you actually seeing value? Take a look at the polling question and respond using the polling tool. So how concerned are you with your organization's ability to meet your value-based care financial and quality goals today? So we have some level of concern, right? 74% of you guys have some level of concern about your ability to meet your financial and quality goals today. In our survey, we asked our respondents, are quality improvement and financial incentives aligned? How do you see this shifting in the future is what we're gonna kind of talk about. Our research found that while most respondents are seeing some quality improvements as a result of their value-based care efforts, their financial improvements aren't really keeping pace. I'd like to open this up to our panel. And Theresa, what do you think is contributing to the disconnect here?
Thank you, Stephanie. In my role at the AAMC, where we work with teaching hospitals who are implementing these models, one of the things that we are consistently hearing is that most providers join value-based care models in order to improve quality. That is their primary emphasis. Certainly financial goals feature into the decision, but that's rarely the only consideration. So it makes sense that our providers are in fact engaging in the various forms of care transformation that underlie these models, whether that's working on transitions to care, preventive care measures, streamlining processes, avoidable utilization. And so they are seeing these quality improvements. The large question is whether that's actually linked to financial gain, and that is extremely dependent on the specific model you're signed up for. Some models are better than others at accurately tying a financial result to a quality improvement initiative at a given organization. So I'll use two programs to illustrate this difference, BPCI Advanced and the oncology care model. In BPCI Advanced, there's a relatively sophisticated regression model that ties a particular organization's results to a variety of factors, including secular trends, what peer group you're in, are you a teaching hospital, what geographic region are you in, and whether or not you were able to reduce utilization. And so we have seen that the organizations that we're working with in BPCI Advanced have made large reductions in avoidable utilization, and for many organizations, that has led to financial improvements in the model. In contrast, in the oncology care model, the risk adjustment is not anywhere near as sophisticated. The risk adjustment for these cancer patients does not include cancer stage, and it doesn't include anything like, do you have metastatic disease? Is this your second round of chemo? Did it not work the first time? Do you have genetic reasons why you need a specific kind of expensive drug? And because of this lack of risk adjustment, even though the participants in the model are making really good improvements in the quality of cancer care, that is not reflected in their financial results. So I think the bottom line answer is all models are not created equal. Some of them work better financially to tie the actual improvements you're making as a provider to the outcomes that you hope to see financially.
Thanks, Theresa. That was helpful. I'm curious if the other panelists have a perspective on this and would like to weigh in, Nicole, John, or Jessica. Okay, I think we'll move on. Just a reminder for our participants, if you do have a question at some point throughout the webinar, please use the Q&A button at the bottom of your screen to enter in your question, and we'll make sure we get to them as we move throughout toward the end of the webinar. So our next topic is really around finding the balance. And we found in our survey, right, how are organizations balancing investments in people and technology and services. And we saw our respondents find it pretty important to find that right balance, right? Technology platforms are super important, people are super important, services are super important. But being able to access all of them, it can be difficult or challenging. And sometimes these are nebulous terms, right, with some crossover. So we define them as you see them here. But we know that this is a big challenge for organizations as they work through how to participate in these value-based care programs. Where are they really going to put their time and money and energy on making that balance? And I'd love to hear from Jessica. I'm sure you guys have dealt with striking this balance at Northwestern. And can you talk about that a little bit? What's your approach and where have you focused your thinking?
Sure. So Northwestern uses Epic, and we've put significant investment into implementing Epic across all inpatient and ambulatory settings. Our internal analytics team leverages data from our EMR for tons of population health initiatives, a lot of them centered on quality measurement and performance monitoring. But when it comes to working with Medicare claims associated with our bundled payment, our ACO programs, to date, we have partnered with DataGen to support our claims analysis. I think, for those of you who are also participating in these models, I'm sure you're aware that, you need significant expertise and resources to really make the most of your claims data in order to identify care improvement opportunities and to also just keep up with the month-to-month changes that might happen in the file formatting. It helps to have a partner who is on it and has a dedicated team focused on that. And historically, we have not had the internal bandwidth to take this on. And so that's why we've chosen to partner with an external team for that process.
Okay, great. Any other thoughts?
In the ambulatory care space, we find that it's really important to leverage, as you said, Stephanie, earlier, it's hard to find the perfect balance of these three, but it really is the secret sauce to find that best mix. Without strong data, you can't take the right actions. Without the right people, you can't be successful with those actions. Or to be able to enter the right data, to be able to get the right reports and analytics. So it really is that trifecta of finding your secret sauce.
Right. I'm curious if, and Jessica, maybe you can answer this too, is there, if you're thinking about kind of the acute care or the traditional facility component of managing care and value-based care versus ambulatory only, is it different, or is it pretty much the same when you look at these three types of resources across the board?
We don't really think of approaching our technology or analytic investments as inpatient versus ambulatory. Northwestern is a 10 hospital system, and we have two extremely large multidisciplinary employed groups. And so, we try and take a holistic approach, and a lot of our initiatives cross service settings. Just one example, oncology care model that includes outpatient chemo. We're focused though on reducing inpatient admission. So there's a lot of things you could do on the ambulatory side that affect how care is delivered on the inpatient side, or how unnecessary utilization on the inpatient side could be prevented. So a long way of saying that, no, we don't really separate those out.
Okay, and the technology components, kind of, you have a Epic enterprise-wide at Northwestern, right? Across
Correct.
The entire system. And there's kind of equal ability across that to leverage those tools along with the kind of other components to effectively impact how the workflows happen to drive results, right?
Yes.
Okay, great. So very helpful. Thank you, Jessica and Nicole, for that. Moving on, next we're going to talk a little bit about kind of practice transformation, right? One of the biggest potential changes value-based care can drive is that true and valuable practice transformation. When we say practice transformation, we're really talking about the practice of medicine, not necessarily a particular physician practice, but how are we delivering care and how are we able to transform that as we kind of move along. Our survey respondents believe that value-based programs are here to stay, and what that allows us to look forward to is kind of a true transformational change in how care is delivered to patients, right? And that delivery reform. So value-based payment models impact payment change and reform to drive sustainable change and delivery reform. So Nicole, as providers begin to really work on that practice transformation, what are some of the critical things they should keep in mind?
Well, it really goes back actually to that previous slide. We always look at people, process, technology in our work and practice transformation. We look at what are the core components that you need in order to achieve your overall goals of having a healthier population of patients and caring for that patient population. So what care coordination do you need? What care management do you need? What type of dialogue do you have with your hospital systems, your specialists? Are you an enterprise-wide system as Jessica is? Or do you have to go between different systems as a more community-based provider? So it depends on where you are. To then first assess what outreach do you need to have to build your network and create that medical neighborhood through care coordination, care management, data transfer, and data sharing. How are you going to be able to communicate and establish protocols with those specialists that are also caring for your patients? And then how are you going to change your team internally to support this? Because we cannot work in silos. We really need to have strong team-based care to be able to achieve all of those goals. And then how are you going to leverage your technology, your EMR, to understand your patient population? So there are many, many aspects. First, team-based care. Second, networking and building your medical neighborhood and how you're going to communicate with that medical neighborhood. And then at the core of all of those is your patient population. Who are you caring for? And having a strong understanding of that base.
Great, thanks, Nicole. And this is, when you think about the concept of delivery reform, does anybody have an assessment of kind of where we are in that model as an industry? Is that happening? And are we seeing it happening slowly, moderately, quickly?
It's a very interesting question. I see a couple mics going off mute, so I'll let others go first.
I would say that broadly thinking about care delivery reform and how COVID has affected it for this year, for years to come, I would say that population health initiatives have accelerated during this time. We've had to get creative with how we think about managing a large population during a global pandemic. So one example of different population health tools that Northwestern pursued during this time, at one point we had a huge influx of patients who were getting tested, and we wanted to be calling them to update them on their status, and we honestly couldn't keep up with the pace, so we leveraged a new technology platform via texting to do that. We also use the texting to help us monitor patient symptoms, so texting out surveys saying like, hey, go here, let us know, are you having a fever, are you having any other symptoms? And based on the responses we got, they got a warm outreach. And that's just one example. I think that we're also considering how we can utilize things like telehealth. I'd say our adoption of telehealth has advanced tremendously. I mean, there's tons of articles out there that say that COVID has ramped up telehealth 7 to 10 years. And so I think that's definitely true. And all those things are tools that we will hopefully continue to leverage or be able to continue to leverage depending how payers treat these different policies long term, that will really accelerate how we approach healthcare and enable us to do so in a much more population health based manner.
That's super interesting. So Jessica, I'm curious on the texting platform, right? One of the big challenges in population health or value-based care is always engaging patients in the right way. And I've been reading and hearing a lot about these texting platforms because it really lets you communicate in a much quicker way, right? And enable the patient to engage a little bit better. Do you think it's having an impact on patient engagement? Are patients feeling more or less comfortable with their healthcare in light of a pandemic? Is it making an impact on multiple fronts, do you think?
Well, first, just taking the texting piece, we tracked the rates that patients actually not just read the text message, but actually clicked the links that we had sent them. And it varied across the different work streams. We had a work stream for positive patients, presumptive positive, negative patients. And, I'm forgetting the exact numbers, but it was safely like 50% of patients that were actually clicking through the links that we sent them. And that's, as anyone who's been involved in that kind of outreach before, know that's an extraordinary success rate. So I think, yeah, just from that piece was really successful. And then on the telehealth side, at least anecdotally, we've heard that patients really like telehealth. Our telehealth rates are really up. So, clearly they're continuing to use them. And I think almost equally important, the providers really enjoy telehealth as well. And I could go on and do a separate webinar about like why telehealth is great, but I won't. But suffice to say, I think people have been surprised how well telehealth has worked.
Mm-hmm. Yeah, and that's a highly high value service, right?
Yeah, absolutely.
Yeah, Theresa, your thoughts?
I would echo Jess's comments about telehealth having been extremely accelerated in terms of the rate of adoption, and thinking specifically about how providers in value-based care were able to respond to this pandemic. Jess, I'm sure that this is something that you also experienced at Northwestern, but we've been hearing from a lot of the hospitals that we work with that because they were already participating in value-based care models, which came with telehealth waivers, they had staff in place, they had plans in place, and in some cases, we talked to organizations that were able to meet their 5-year goals in terms of telehealth adoption within a matter of months. But they already had some degree of infrastructure that helped them respond to the current pandemic because of their previous experience in value-based care models. On the flip side, we are hearing about some disadvantages. As I'm sure everyone on this call is aware, there have been enormous disruptions in the healthcare industry as a result of the pandemic. And some of them have hit directly on the care transformation that hospitals and other providers are pursuing through value-based care models. One of the key things that comes to mind is the post-acute care space. So one of the things that we're hearing from the hospitals that we work with is that they have designed practice transformation around seamless handoffs to preferred providers in the post-acute space. And because of this massive disruption, there has been limited capacity in the post-acute care space at SNFs, at inpatient rehab, for home health. There's been limited PPE, there's been limited staffing, and all of that has disrupted the best laid plans. So in certain circumstances, providers are using this as an opportunity to develop much closer relationships with the post-acute care providers in their community, and they report that they hope this continues for many years. They hope that this becomes a new normal of close communication and effective communication. But it has been highly disruptive, even though there are people who are stepping up to meet this challenge and turn it into something that's sustainable in the long term.
One final thing I'd like to just add to that is you see a lot of articles out there today about the pandemic is we both or all have been speaking to the pandemic speeding up not only the adoption of telehealth, but the adoption of value-based care and prospective payments, that people are now saying, I'm spending this time looking at my population, seeking to keep them well and healthy and with a high quality, low cost of care, with high patient satisfaction. I should be paid prospectively for that, and then link it back to the quality as the retrospective payments, versus they're feeling the burden of relying on fee for service, and now they're experiencing that there is a better way to do things, and there's other opportunities. So it'll be interesting to see how things evolve.
Yeah, it's really fascinating conversation, right? A lot of early concern. It's all relative, right? Early in the pandemic world is 3 months ago. There was all the concern about this slowing it all down. And now it's speeding up. You know, Jess said it, Nicole said it, Theresa, you all said it, that this is potentially a big tailwind for value-based care and payment and delivery transformation, because we're already seeing that happening. So it's really fascinating to think. But let's move on. So I think we're gonna talk a little bit about analytics. So analytics is a super important part of being successful in a value-based care environment, right? That population health, understanding the analytics around your population and how you can impact that, and really looking across all of that. We asked our survey respondents how they're managing their analytics needs. And the responses point to a very fragmented market, right? In our work, we see the same thing happening. We see some organizations leveraging analytics software to drive insights. It's not always that simple, right? You're really looking for insights, and dealing with data doesn't always offer that. Some organizations are relying on consulting firms to help drive the insights from the data. And others are kind of sticking with their EMR solutions, or have invested in a population health solution that provides analytics to really help understand that population. And the next, Alex. Kind of regardless of how organizations are really looking to solve their needs for analytics and insights, it's complex and it's challenging. And John, I wanted to have you talk about, from your perspective, how do you see the industry viewing analytics, and how do you see your partners using analytics to make better use of their data?
Thanks, Stephanie. Kind of reiterating what all the other panelists have been talking about, data analytics is important. It's an integral part of VBP programs. Stakeholders rely on that data to make informed, data-driven decisions. This has become even more apparent in the past 4 months due to COVID-19, where participants are relying on the most recent data to make decisions of whether to stay in these programs to what extent. The team, where DataGen is the data experts and content experts. We're working on it with a team, with our clients, a collaborative team of stakeholders, stakeholders such as physicians, C-suites, administrators. Those stakeholders drive the questions and overall focus of what to look at in the data, and they're working with the analysts, program managers, and the content and data experts such as ourselves or internally to translate those questions into informative and actionable information from the data. So when we create models, it's important to understand the lens in which the data model is needed to be looked at. Sometimes multiple lenses can fit into a single model, whereas other times it can be more cumbersome and complicated to have all viewpoints in a single model. To give an example, in like bundled payment models, you can have both financial and clinical metrics together, and you can look at both of those in the model, and they're very coherent. But with MSSP data, looking at both the public health and population health view of the data, as well as the financial tying to reconciliation information in the same model, becomes complicated and cumbersome, and it may not translate well or be completely understood. And having two separate models and two separate views of that data coming from financial and the population health view is a more informative way of looking at it, and easier to understand for the stakeholder that's actually looking at the data. One of the big things is to enrich the data is the key to get the most value out of a data set. A simple example would be diagnosis code. So, with the claims data for Medicare, you have your diagnosis codes. There's thousands, or with ICD-10s, probably tens of thousands. You're not going to want to stratify patients by their specific diagnosis code, but applying a certain method to group those patients together, such as HCC or CCSRs or a proprietary from 3M, any of these types of methods, so that you can just pull out, diabetic patients from your population. and not having to look at specific diagnosis codes. Those methodologies are for just that one methodology of just classifying patients' conditions. As I just mentioned, there's multiple different methods, and working with the analyst and the stakeholders to see which method works the best. As in, is there already a method in place in the organization so that if one team is looking at HCCs, the other team is also looking at HCCs, so the definition of diabetes is the same. Whereas if there is no standard of definition, then it's a question of which one is most appropriate to answer the question and which one is the easiest to explain. So you can come up with your homegrown method, but that might be harder to explain and convey to other stakeholders. And that's what we've done with our partners or with our clients and practices, such as Jess's team, to work with them to see what method works best and lay out the options for them, being the content and data experts, to see which one would work the best for them. And so information itself, in my opinion, of looking at the information, can be classified into two different buckets. You have standalone information and monitoring information. Standalone is basically one-offs or hypothesis questions or descriptive data. It gives the context of the population or program. So those are descriptive statistics such as, what's the percent of my population that are diabetic? That alone is not something to, track every month. That might be just something to give context to at the beginning of a PowerPoint slide.
Hey, John.
But digging in deeper, yes.
Hey, John, there's a question that just came up. Maybe you can give a little context. The question is, what are HCCs and what is MSSP data?
Okay. HCCs is hierarchical clinical classification category. It's just a method from CMS. I forget which department, but it's just a way that they categorize based on ICD-10 diagnosis codes to a category. They use that for MSSP data. They use it in the bundled payment, BPCIA Advanced, and use it for other programs as well.
Primarily to risk adjust, right? To be able to stratify a particular Medicare patient who has more chronic conditions, and they get potentially reimbursed at a higher rate or a lower rate based on their HCC scoring, right?
Correct. You can do either or. One of the outcomes of it is to create a risk score, but you can just use the mapping itself just to classify patients as diabetic.
Right. Okay, great. Thanks.
What was the other question?
No, it was and MSSP data. I think we're good. And I'm sorry for interrupting you, but I wanted to get that in context.
No, that's fine. Yeah, the MSSP data is the Medicare ACO data. Great. So going back to the information, the standalone descriptive data, looking at your patient population is diabetic, what percentage of that, but knowing what, so looking in deeper into that data of seeing, how many readmissions those diabetic patients are going to the hospital for uncontrollable diabetes, or, put in whatever readmission rate you want to look at, and tracking that over time to use that data for a discussion on targeted interventions, and so that you can track that data and monitor that data and give it as actionable information to look at, to see if they're starting to decrease in those readmissions, if it's right after a point of doing an intervention, that intervention is working. If it's staying the same or increasing, then it's reevaluating that intervention and using that data as an actionable method. So going like the standalone data can also drive questions and looking at the population, see what the context is, so that you can make those decisions to create those monitoring metrics. So explain this, data models don't happen. You can't just upload the data into your platform, it'll spit out answers you're looking for. you still need humans with hypothesis or questions from stakeholders, from program managers, to get a meaningful measures to transform care and make decisions. As COVID-19 continues to unfold, having the most recent relevant information is key to making decisions, with the understanding that that information predicted forward will have greater uncertainty due to these new confounding factors, environmental and policy, that are outside the control of the provider. As we see currently, you know, from month to month, the environment just changes. As we know, this month, all these different states are, you know, seeing a COVID spike that may not have been predicted from last month. So the population, the patient population for the hospital is increasing for COVID patients, but as well as for policy changes, you're seeing a decrease in elective procedures. So you'll see greater variability with lower numbers in programs such as bundle payment programs, where higher volume results in higher stability. So that creates a higher variability within the population.
Okay, great. Any other thoughts? Jess, you did come off mute. I don't know if you had a comment.
Yeah, sure. Just quickly, in terms of the type of challenges you encounter, a big one is just what you get from the payer and when it comes to trying to analyze payer claims data. You know, Medicare actually does a really good job relative to a lot of other commercial payers in terms of the amount of data that they give you. But I know everyone who's worked with Medicare claims data before is aware that one of the biggest challenges is the lag that you get the data. So, you know, 3 to 6 months lag between when a service is utilized and the claim is dropped and when you actually get that claim back in your data dump. So I think one, you have to recognize that you're going to rely primarily on your Medicare claims for understanding opportunities and designing your strategy versus real-time intervention. So you just have to accept that. And then you kind of patch that hole to the extent possible by leveraging your internal data. So if I'm in a joint bundle payment program, one of my key metrics is how many patients am I discharging to a various post-acute location. That's information that is housed in your medical record most likely, so you can work with your internal team to build a report that lets you track that key indicator real time. Whereas your Medicare claims data, you probably use those to identify in general that that was one of your areas for improvement. And then I'd say the second challenge is that even though Medicare does provide really robust claims data, sometimes certain fields are missing. Like an example, BPCI Advanced. I don't know if they've changed this, but for a while, at least they weren't providing rev codes, which is what we use to identify ICU utilization. And so the way you deal with that is be a good partner and communicate with Medicare, advocate for what you need and tell them why. And I think that Medicare, to the extent that they understand why you need something to actually transform care, will try and work with you and their data vendor to the extent possible.
That's great. That's super helpful. Jess, have you guys had any kind of success strategies in working with the commercial payers on data? I know that's a big, hairy question, right?
So I'll admit that I'm new to the commercial space. That's been a recent addition to my portfolio, but I'd say I've seen limited success thus far. I mean, some payers are still giving us PDF reports.
Nice.
And so, you know, we literally need to like look at the PDF and like type in the numbers and like shout out to Maggie Command who does that for us. But yeah, definitely not as much success as on the Medicare side.
Okay, great. All right, let's move on. I think we're on to a third polling question. So in light of current events surrounding the COVID-19 pandemic, would you be more or less interested in value-based payment models now than you were 4 months ago, assuming a gradual return to normalcy and increased resources in healthcare? And just a reminder, if you do have a question, please use the Q&A button at the bottom of your screen. We'll be getting to a Q&A session pretty shortly. So interesting, 56% are more interested in value-based care payment models than they were before the pandemic. It's really fascinating to see how minds are changing and things are thinking. That kind of leads us to that next topic, or the last kind of panelist discussion before we move to Q&A, and that's what's next for value-based care in the new normal. The big question, we've already talked about this a little bit, and we want to hear from all of our panelists. What's next for value-based care, right? There's a lot going on at CMS, there's a lot going on with commercial payers, and clearly there's a lot going on in the minds of healthcare leaders and provider organizations. What do we think we should expect moving forward? Theresa, let's start with you with a discussion, I think, on national policy changes, and we'll move on to Nicole and through the panelists. So take it away.
Thanks, Stephanie. Yes, as you say, I can talk to our audience about the national policy scene. One of the things that we've been hearing with great consistency from the administration is that they continue to have value-based care being one of their primary priorities in the healthcare environment, especially in light of the pandemic. So rather than having it be in addition to, we've been hearing from the administration that they see value-based care as a way of addressing the current pandemic and also being more resilient in the future in light of any potential future emergencies. So we do see that. We see bipartisan support for value-based care in Congress. So for all of you who have increasing interest in this, in light of 2020's events, I think that makes a lot of sense. Value-based care is not going anywhere. In terms of helping providers who are currently participating in value-based care models, as many of you know, many of the models, if not most of the models that people are currently participating with through Medicare do involve downside risk for providers. And CMS has been very responsive to those providers by either entirely eliminating downside risk or substantially mitigating downside risk for value-based care participants during the course of the pandemic. So the specific details depend on the specific program, but overall, that's the trend we see. We also see that in many programs, CMS has limited or entirely eliminated reporting requirements from participants to try to ease the provider burden during this very unique time. So that's what we're seeing from CMS, a voiced commitment to continue with value-based care going forward, coupled with a reduction of burden for providers today. In terms of when we're going to see new models, if you would have asked me this 4 months ago, I would have had a very different, but as it is, we have a pandemic and we have an election year. And I don't anticipate that we will see anything groundbreaking or controversial in terms of brand new models that nobody's heard about for the next 6 months. I think CMS is really busy doing a lot of other things. They have said that they remain committed to the models that have already had timelines rolled out, although many of those new models, which were announced in 2018 and 2019, many of those new models have been slowed down a little bit in terms of their implementation, simply to accommodate the present situation. We also do continue to see some new models coming out that would start in 2021 or later. One of the questions I get a lot is what's going on with mandatory models. As some of you may know on this call, in 2019, CMS announced 2 potential new mandatory models that would have been mandatory downside risk in the area of nephrology and radiation oncology. We have not seen CMS finalize either of those policies. As I mentioned just a few minutes ago, I don't anticipate that they would do so this summer or fall. However, that is a possibility, and I think it's something that we should be aware of and looking to in 2021 and beyond. CMS has a statutory obligation to decrease costs or improve quality without increasing costs, and they see one way of meeting that obligation is to mandate participation in value-based care models. So that is something to consider as you think about what kinds of skill sets you want to develop either internally or with partners in terms of building post-acute care networks, having access to data analytics, and having clinical champions behind various care redesign initiatives. So that's where I would say, in summation, it's not going anywhere. If you're in a value-based care model right now, don't worry. CMS hopes to have your back in terms of risk, and stay tuned for what happens in 2021. It's dependent on a wide variety of variables that are currently very difficult to predict.
Yeah, that's great. Nicole, I think you were going to follow up on kind of what's in the heads of the payers. What are they thinking?
Well, it's very interesting from the payer and the provider standpoint. I think that the payers are really looking for the providers to start to take on more risk, to be more of a collaborator at the table. And that requires a lot of trust and transparency in that data sharing, which we already spoke with Jessica about earlier, is on the commercial side especially, we're not seeing a ton of that data sharing. And I think that needs to be very much amped up in order to get to where we need to go. But we're seeing in New York State, there's a huge push for value-based payment, and especially on the primary care side. I think that the desire to get providers to take on more risk, to step outside their comfort zone, is really going to be where we go next.
Okay, great. John, do you think anything around this fragmented analytics market's going to change at all?
I don't think so. I mean, if anything, providers might put more analytics in-house, but as the market is this fragmented, we'll still see providers going to different resources, picking whichever option works the best for them. And I'm not sure if providers are willing to change drastically of how they're processing everything, unless they want to go through a complete redesign or overhaul of their data system itself.
Right. Okay, great. Jess, when you think about Northwestern and moving forward, what are you looking forward to, or what are you worried about? How do you think it's going to play out for you guys?
Well, I think that it's a little different when you think about short-term versus long-term, because short-term, we're faced with some immediate policy decisions about a number of our programs. COVID is impacting program performance in terms of number of patients attributed to us, risk adjustment, which impacts our targets or benchmarks, and then actual utilization, which of course affects financial performance. And so at least in the 6-month period we're looking at, we have to do tons of analysis to try and project what performance could look like in our Medicare programs in the near term, and decide what type of changes, if any, we need to make in this immediate period. I think long term, our goal and dedication to population health is the same or possibly increasing not because we didn't believe in it before, but because we've had almost a little experiment in front of us to see what can you achieve when you put a lot of trust and investment into population health tools and strategies. So we're very eager to accelerate those, and happy that others in our system have had a chance to see the power of population health, so to speak.
Yeah, that's great. Interesting. So I think we'll move to some Q&A. I think we have a few minutes left. There are a couple questions here. Just a reminder, if anybody has a question they'd like to direct toward one of our panelists, please use the Q&A button at the bottom of your screen. I have, I think, 2 questions. There are 2 that are on a related topic. I'm not sure if they're from the same person or not, but this is really around value-based contracts with manufacturers. So I'll just read this as it was typed in. In other countries such as Canada, when a patient is prescribed a treatment option, the manufacturers of that product get involved to ensure the patient is taking the treatment correctly to help ensure the patient gets the expected outcomes. Do any of you see large health systems and payers partnering with manufacturers more to really focus on decreased cost and improved outcomes?
Well, I personally have not been involved in any such arrangement with Northwestern. Not to say that they haven't existed. I don't pretend to know Northwestern's full history and going-ons, but I know we're certainly aware of those types of arrangements. And I think, you know, from our perspective, when you think through whether it's worth engaging in that type of arrangement, one, there could be considerable upfront costs, so you have to have that available revenue to fund that. And then two, sometimes what might work in one model might not work in another model. So we had conversations with a particular company about a device that would be implanted for cardiac patients, and they were, you know, advertising it as something that could help out bundled payment performance. But when we looked at the cost of the admission for actually putting that in, you'd see, you know, that would be a guaranteed loss for that episode because that admission itself has such a high reimbursement tied to it. Where that might work actually is in a more ACO type world where, you know, implanting that device actually could prevent 2 admissions way down the road. So those are the things you have to try and think through, you know, with the overall caveat that we don't really like that type of thinking to guide patient care in general. It's always what is best for the patient, not, you know, the finances. And so, yes, we go through that thought process, but at the end of the day, we just want to do what's best for the patient.
Yep, that makes a lot of sense. We've seen, just in our world, in our consulting world, we've seen some, you know, activity around implants for joint replacements, right? The manufacturer is partnering to really drive some economies of scale on that, you know, total, you know, that comprehensive joint replacement process. And we've also seen the life sciences companies kind of partnering with solutions for diabetes, for instance, right? To offer patient solutions, digital solutions really to help with medication management, right? And there are different incentives, right? The pharmaceutical company clearly wants their prescriptions to continue to be refilled, and the provider organizations clearly want the patient to continue to take their medication to manage their disease. So we're seeing it. I don't think we've seen it in tremendous waves. So that's interesting. The other question here is, in the pandemic, value-based payments might be good, but if we consider the growth in specialty pharma, do we still want to take on the financial risk of population health? So I think that question is really big. It really goes beyond specialty pharma. Do we think there are enough tailwinds in kind of the value-based care world that the risk is the reward potentially outweighs the risk, right? As we look at how cost and outcomes progress. Any thoughts there?
I saw Theresa unmute herself, so yeah. She should go.
Thank you, Jess, and thank you, Stephanie. I can speak to this from my experience working with the oncology care model, which does include the cost of drugs, including specialty drugs. I would say that, as with anything, the devil is in the details, and you need to be extremely aware of what costs you're responsible for, whether that is adequately risk adjusted, and if it's not, be extremely wary of taking on risk for that. So as I commented earlier on the oncology care model, there is not any risk adjustment associated with stage, current clinical status, or molecular markers. But as many of you on the call would know, specialty pharma is directly tied to molecular markers. And as a result of that, without that risk adjustment, you're on the hook for an extremely expensive drug. That's something to be extremely cautious about. And I have not yet seen a model that adequately risk adjusts for specialty drugs. On the other hand, in BPCI Advanced, beginning this year, drugs are a part of the total cost of care, but there's a cap at $25,000. That makes the risk adjustment more effective, in part because it's not based on cancer. These are episodes. Some of them are surgeries, some of them are medical, either acute or chronic. But the fact that there's a cap helps control for some of the loss on an episode by episode basis, not just the overall stop loss. That's a somewhat technical way to say, be very aware of what you're taking on risk for, and try to understand whether the interventions that you are putting in place as a provider, whether they have the ability to directly impact those costs you're responsible for. If you're responsible for the total cost of care that involves admissions and your primary care practice, maybe you are aware that there are certain preventative actions you can take that will ultimately have an effect on those admissions. Or maybe you're more confident in what happens in the outpatient space. Maybe that's the whole area that you wish to take risk for. As an intermediate step, maybe you're more comfortable with ED costs because you think that that has a more direct line of sight between the care you're providing to patients to the actual care that they need. But specialty pharma should be something that makes you think very carefully and talk to any actuaries you're connected to, whether they're in your organization or someone you partner with, before taking on that risk.
Great. Jess, any other thoughts?
I mean, I think Theresa hit the nail on the head with the comment about if a model includes drugs and drugs are a majority of the average cost of an episode or a patient's care, and there's not adequate risk adjustment for the drug, it's not going to work, and not a lot of people are going to want to participate in that model. I think, though, you know, it's important for us all to think about the question of how do you address drug expenditures, and there's not a simple answer. I mean, I think thinking about things like, you know, measures, like focusing on that, like generic prescribing, things like that. But if anything, in participating in oncology, the oncology care model, has taught us how challenging it is actually to really impact drug expenditures, because it's not necessarily a question of here's the generic, here's the specialty drug. It's what fits for the patient's lifestyle. Perhaps the specialty drug, it has an administration schedule that requires the patient to come in less often, and that patient's a single mom who doesn't have childcare. So versus the generic that requires you to be in twice a week or something like that. So those are actually some of the bigger considerations that guide what's best for patient treatment when it comes to drugs. So that's a way of saying I think it's an important question, but it's one that's really hard to know how to appropriately address when it comes to alternative payment models.
Got it. Great. Thanks. Well, I think we have used up all our time. Thank you to everyone who stayed with us for the full hour, and a special thank you to Theresa, Jess, John, and Nicole for being our panelists. I thought it was a great dialogue, and I've really enjoyed being here with all of you today. So thank you so much, and have a great afternoon.